Everyone, I just wanted to send this video out if you want to look at it. It's in reference to some ventricular rhythms we haven't really been across and done very much. But you do have a test coming up on Thursday, and we've hit on them, but I wanted to give you a little more of an overview and some things you may want to look up in your book. I'm trying to get you moving on. I know it seems like a lot coming to you, but continue to work on your rhythms, and I'm going to throw in a couple more ventricular rhythms as we go. When you first look at your rhythms, remember, look at from a distance. You want to know the rate, the rhythm. You want to know P waves of QRS, QRS for P waves, and on and on and on. If you look at this rhythm, you notice there's no P waves. You really notice there's no narrow complex QRS, so it's really not coming out of the atrium. So you know that it's a ventricular in nature rhythm. I wrote at the top already that the rate's approximately 26. I did the measurement for you. The rhythm is regular. The width is greater than 0.12. So this is actually, if you look at it, an idioventricular rhythm. Idioventricular actually meaning that it's coming from more of the Purkinje fibers, lower part of the heart or around that area of the heart. Since the rate is around less than 40, you see it right here, less than 40, you got to consider where it's coming from, and that's what makes it IVR. Anything above 40 is accelerated IVR, and anything above 100 is ventricular tachycardia. I know it sounds strange because we have that 40 to 60 process in there also, but anything technically above 40 is considered accelerated IVR. But again, look at the width. Please make sure you look at the width that you're dealing with, and you still need to rate and all, and this is what idioventricular looks like. Here's an accelerated IVR. Please remember, looking at the rate is approximately 46. That's above our 20 to 40 that we're looking for normally. So it's accelerated in nature. You're going to hear some people talk about it that it's still IVR in the big scheme of things, but technically idioventricular should be less than 40. Width is greater than 0.12. We already talked about that. There's no P waves, there's no QRS. You got regularity going on. So there's a lot of things going on here. So remember, accelerated IVR, wide complex, over 40. You can never go wrong. It's pretty easy to look at. If you're looking at this, you'll see some other things like right through here. We'll talk about it with 12 leads. It's a little different. But from your basic recognition at this point in time, it's accelerated IVR. Here's one we really haven't talked about. We spoke earlier about premature ventricular complexes. Premature ventricular complexes. But if you look at this rhythm here does not come early. It does not come early. And as such, it is called a ventricular escape rhythm or beat. What's happening here is, as you notice, your QRSs are marching out here, 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 and we would expect one somewhere around here. Well, since it's not coming, the ventricles don't feel that impulse that it's supposed to be getting, so it does one of its own. And when it does one of its own, that's a ventricular escape beat, trying to compensate for the other beats that aren't there. Pretty easy to understand. Remember, it's not premature, so it's technically not a PVC. Here's another ventricular escape. Again, look at where it's located. It does not come early. If you'll look at your rates through here, again, going down, let's see if I can move this down a little bit. Again, just looking basically at your rhythm from here to here, we would expect another one with somewhere around here. Since it didn't find it, it had to give a ventricular rate to make that, to attempt to make the ventricle pump. This was an interesting rhythm we talked about. So far, of the other rhythms we have looked at, they have all been unifocal. Unifocal or uniform means they all look exactly alike. If you have multiple ones on a rhythm that they all look alike, they're called unifocal or uniform. With that happening, please remember that if they look different, And this rhythm was pretty interesting. Yet they look different, and as you can see, you have one here and one here, and both of them look different. When you're looking at these two PVCs, these are called multifocal or multiform. They look different. They're coming out of different areas of the heart. A couple other things are happening here if you really, really want to look at this rhythm as best as you possibly can. We are actually looking at a rhythm here that is falling on what we call an R on T. I'll show that a little bit more to you here in a little bit. R on T phenomenon here. And this one here, if you're looking at it, I haven't really done the measurements between what we're looking for, but 300, 150, 100, not quite 75, 300, 150, 100. This is actually a PVC. It actually comes just a little early, not a whole lot. And with most PVCs, if it's coming early, they're going to have what they call a compensatory pause right here. Just a little longer than your normal pause from here to here. So a compensatory pause, when you're looking for premature ventricular contractions, comes early with a compensatory pause. You won't see the compensatory pause with your escape beats. I hope this helps a little bit. We're going to show a few more of these. Just giving you a quick overview for you to go back and look at. And, you know, it's in, I forgot what chapter of your book, but there's a ventricular chapter of your book that I would probably look at just to get yourself. I'm not going to throw anything hard to you on Thursday, but I need to get you moving on to the next step. We've been doing this for quite a while, and you guys are actually getting pretty good at it. So I want to continue to move you forward, and this hopefully will give you something to look at. So looking at this one, it's pretty easy. If you'll notice, I got PVC here written at the top because that's what it is. We're PVCs. As you'll notice, they are uniform in nature. They look alike. They come early. See how they come early, and see this big compensatory pause here? Okay. Compensatory pause is what it's called. And you can see a pause that is longer than what we see between here. So that's basic PVCs. Things we're looking for when we're looking for PVCs. More than 6 a minute we have concerns about. More than 10 real concerns. But for this purpose right now, we could probably measure how often it comes through if we were to do the measurements in time. I'm not really worried about that right now. But the big scheme of things, we do have PVCs happen quite often here. It looks like if we were to measure this, probably more than 10 a minute. Especially since if we look at our 6-second strip is 1, 2, 3, 4, 5, somewhere around there. This may be right at a 6-second strip. So if we have 2 per every 6 seconds, we are going to have approximately 20 of these a minute. I would have some concerns. So it's just something to look at. This is a quick overview. You can do a little more better measurements than I can right now. I just want to give you a quick video that you're not going to take too long with, but you can go back and look at. Here's some more multifocal PVCs. This was a good one here because it actually shows you 3 different PVCs. All of them are coming from technically different areas of the heart. Or not at different areas, but if you look at it, they're all pointing down, but they're different sizes, a little bit different morphology, they call it. So I would consider these multifocal PVCs. And as you're doing it, I actually put trigeminy in here. That means that every third beat, there it is, 1, 2, 3, 1, 2, 3 is a PVC. So this is multifocal PVCs with trigeminy. PVCs, and I'm not even sure they're PVCs when you start looking at it. I got to do the measurements. If they're not coming, early, they're actually not going to be PVCs. They may be more multifocal escape beats. And you have to do the measurement a little bit, but it's something to think about that they may be trying to overcome what the heart's not giving out sun. So I'm actually looking at this again, and I'm thinking about it's going to go multifocal escape beats with trigeminy, or trigeminy PVCs is another way it can be called. Another look at trigeminy. This one was really interesting because if you don't look real close, you will notice that this does have a P wave. These are a little wide. I'm looking at just, let's see, 0.4, 0.8. They're right at 0.11, which is our limit. Too much wider, and we're definitely going to have some aberrancy going on at in our atrium. But there's still some interesting issues here. But if you look at it too quickly, it looks like your PVCs, which are here, are pretty much almost as narrow as what you're seeing before. You have to really look at this. These are coming every third beat, so they're trigeminy in nature. So these are some things to look at. Please ask questions about this on Thursday when we get together, but at least it'll get you started looking at some ventricular rhythms. Here's you some bigeminy. Every other beat, as you can read here, you don't need me to do that. They are coming early. You see how they come early here with a compensatory what? Pause. We got compensatory pauses. So this is bigeminy PVCs. And if you think about that, if every other beat is a non-perfusing beat, when you check this person's pulse, it's definitely not going to be what your monitor is going to be showing. Your monitor at this point in time, if this is a 6-second strip, would be 1, 2, 3, 4, 5, 6, 7, 8, would be showing about 80. But if you were to check your pulse on your patient, we could almost measure these. If you check your pulse on your patient, we have 5, 10, 15, 20, 25, 30, 35, 39. Let me do some measurements here. 39 into 1500. Got my calculator right here. Is actually your pulse is probably going to be around 38 beats per minute. So you can see that these are probably non-perfusing beats. You're probably going to have very irregular rhythm. This patient's going to be very sick. You still identify the rhythm, but your pulse is what's going to tell you a lot about your patient. So make sure you know that those are different. This is also bigeminy PVCs. Again, these are probably not perfusing rhythms. See how wide they are? All right. They're unifocal in nature because they all look alike. We could probably, again, measure and have a pretty good idea what our pulse is. We have a compensatory pause. It's actually pretty cut and dry bigeminy PVCs. Very dangerous if there are this many per minute. Another trigeminy, again, early compensatory pause. Early compensatory pause. So they're premature. This is one that I thought was pretty interesting. When we talk about PVCs, we talk about one PVC being a PVC, 2 being couplets, remember that, 3 being a run. Well, here's a run of 4. The thing to be aware of with this, if you really got to be careful about it, is even though it's a run, it's not a run of V-tac. We got to look at our rate. And our rate right here, if I'm looking right, is going to be 1, 2, 3, 4. So our rate's about 75. If our rate's about 75, at this point in time, it is not V-tac. Not V-tac. It is a run of PVCs, or not a run of PVCs, but a run of ventricular run is another way to if it's not premature. Ventricular run. We look here. It did not come early. It did not come early. So I'm going to call this, instead of a run of PVCs, we'll get rid of the PVCs. I'm going to call it a ventricular run, or a run of ventricular beats, something of that nature. It doesn't have to be specific. There's no real words to it. It's whatever you think is going to be best. Just as long as the doctor knows and you're able to document it. Now here's you a VTAC. Ventricular in nature, no P waves that we can actually clear to. You have your QRS and your tail after it. There's your wide complex. It's right just at 0.12 or a little bigger, so it is greater than 0.12. It is ventricular in nature. Our rate, even though it varies, if you'll notice it varies, we have it right at 100, just over 100, getting close to 150, right at 150, even faster at 150, on and on and on. We have a real issue here. So this could be a lot of things going on. It could be that they are getting this patient he's running VTAC. They decided to get him to hold his breath and what we call vagal maneuvers. When that happened, he held his breath for a minute, it stopped it, and then he goes back into a regular rhythm. Could be a lot of different things going on here. I don't like the way that's written. But greater than 0.12, the ventricular nature, this is VTAC because they are over 100 all the way down. So we actually have a run of VTAC here, a run of VTAC. This here's an easier one. Still a run of VTAC. If you want to measure your distance, this is from here to here is 300, here to here is 150. It's greater than 150. Look how pretty much uniform they are. I mean, V, showing the equisential ventricular rhythm. Doing it it's a basic VTAC. It's all uniform in nature. They all look alike. That's something to be aware of for basic VTAC. Basic VTAC. Another very pretty VTAC. They all look almost alike. We have a rate here. We find one. There's a pretty one to just under 300. If we were to count it, that's 6 in the 1500. So this patient is actually tacking out. Let's see what this one says. I'm nosy. 1500 divided by 6. He's actually, his rate is 250. If his rate is 250, don't forget, if your cardiac output equals stroke volume times heart rate, if his heart rate's increased that much, his stroke volume is going to be in the dumps. Going to be in the dumps. So again, be thinking about that, how your patient is doing. This one should be easy. This is sort of interesting when you first look at it. There is no real, this is something a lot of people get at. These rates right here, these things right here, everybody thinks is ventricular in nature, and they are in some ways. But when they're this erratic and have no basic normality to them at all, this is VFib. This right here would be what we call coarse VFib. There's a lot of different ones here. There's very coarse VFib, there's coarse VFib, there's VFib, there's fine VFib, there's very fine VFib. VFib is VFib. I'm going to show you a couple, probably another one here in a minute. But overall, VFib, you need to know what you do. What do you do for VFib? Do not forget, any patients in VFib, you always defib. Very, very, very important. That was an easy one. So again, this is where we at, course VFib. This right here would have scared you. Anything through here. A lot of people will misread this sometime as a very erratic VTAC. I'm only saying he may have a little bit of VTAC here, a little bit of VTAC here, but it's so erratic in nature. The erratic in nature forces it to be VFib, and it's coarse. See how coarse it is? So that should be a pretty easy one for you to recognize. This one's a little different. This one we call polymorphic VTAC. We sort of start seeing some regularities here. Okay, but then they change a little bit more here. And then they change here and change here. Polymorphic means that it's ventricular in nature. It's tacky. It's kind of over 100. But there is some tack in here that we can recognize. Here's a good one. That we can recognize, but they all look different. Looking different is the polymorphic part. Polymorphic part. Monomorphic VTAC. Monomorphic VTAC is pretty. So at this point in time, we have polymorphic VTAC because they all look. They don't look alike, so that's where we're going with that one. This is another polymorphic VTAC we have. Just not too bad. It's close to monomorphic, but there is some changing going on here. You have a little bit different area through here that you have through here. And we'll talk about another one that a lot of people call this one here in just a second. But think about your basics. This is one that gets a lot of people. Torsade de pointes. Torsade de pointes actually means, in French, twisting, I think it's French, of, the point. Twisting of the point. So what you're actually looking for here is pretty interesting. You'll start seeing some consistencies. If you'll notice, this line right here sort of matches this line right here, but it doesn't match this line right here. Twisting to the point means technically these are sort of focused downward. These are more focused upward, then downward again, upward. That's where you get the twisting of the point. It is different than the last one. It is different than the one that you had with the polymorphic V-tac. This is a type of polymorphic V-tac. It is a type, but as a specialized type. There's special treatments for this that you need to know. Another way a lot of people look at it is it's quite large here and then drops down, then it gets up and then it drops down, then it gets up and drops down again. So that's torsade de pointes. And we'll go over that, and there's some treatment for this that you'll learn in the next few weeks. Another torsades. Remember, this looks a lot like this. If you go back, this will look a lot like this back over in here. So, and again, you have that distinguishing up, down, up and down concept. So that's the torsades de pointes. It has a lot to do with the electrolyte imbalance in the heart, usually potassium and magnesium issues. So we have ways to treat this. Figure I'd give you another one. Again, up and down, and look real close. Again, look what these look like. Look what these look like, but they don't look like these. So in the big scheme of torsade de pointes, again, it's called twisting on the point. Some people call it, if you really look, it's sort of like twisting a ribbon. A ribbon. You know, when you twist a ribbon, you've got the wider sides of it, and then you've got the area that sort of bunches up here. So whatever works for you, but that's torsades de pointes. Here's one I think we need to really recognize. We definitely have premature. They're premature rhythms. They are wide and complex. They have a compensatory pause. But the PVC is hitting right on that T wave. See it? Right on that T wave. This is what we call an R-on-T phenomenon. Very dangerous. Very dangerous. You may get one that doesn't cause any trouble. You may get a second one that doesn't cause any trouble. But when you're really, really looking at this, I'm going to show you one in just a minute that leads you into something worse. But you need to be recognizing this, and if you call the hospital, you really want to let them know, I've got a patient in sinus rhythm, looks like, sinus rhythm, with PVCs, and they're hitting on the R wave. I have an R-on-T phenomenon. They're going to want you to start treating that pretty quickly. Here's an R-on-T. Right here it hits early. As it hits early, throws this patient to V-tac. That's what they call conversion to V-tac. Not a good conversion. We would rather have that patient at normal sinus. But this is what can happen. And many times, it completely skips V-tac, goes straight into V-fib. Hitting back on one we talked about earlier, this is accelerated IVR. Look at your rate. 300, 150, 100, 75, between 75 and 60. So at this point in time, we have accelerated IVR, but it's not V-tac, and it's not idioventricular. And last but not least, I'm going to give you one more accelerated IVR. Okay, if you look at this real quick, just count your boxes. We're going to use this one because it's close. 1, 2, 3, 4. It's just under 75 beats per minute. So what is it? Accelerated IVR. I'm going to end it here. This gives you a quick overview of pretty much all your ventricular rhythms. I'm just going to give you an overview. If you got something that you really don't recognize, we can talk about it on Thursday. Or please feel free to, that's what your book's for. Get in there and read up on some of this. They talk about interpolated IVR and things like that. We've hit on it. It's just a wording issue. If you have any questions, you're welcome to give me an email or a call or have them ready for me on Thursday, and we'll be glad to go over it. Have a good week. Bye.